Hello, everyone. Have you ever been in a situation where you're looking at a child's development and wondering, are they just a late bloomer or is there something more going on? Well, in today's explainer, we are going to clear up all that confusion. We're diving deep into global developmental delay and intellectual disability, two topics that are absolutely crucial in pediatrics. We'll cover what you need to know for your exams and for your clinical rotations. So let's get right into it.
This is the classic question, isn't it? A worried parent comes to you and says their child seems a bit slow compared to others. And that's where you come in. Your job is to figure out if this is just a normal variation in the incredible spectrum of child development, or if it actually meets the clinical criteria for a true developmental delay. Nailing this distinction? Well, that's the first and most important step. All right, first things first, let's get our terminology straight. What do we actually mean when we say global developmental delay versus intellectual disability? They're not interchangeable, and knowing the precise difference is fundamental. This is exam gold.
Okay, so global developmental delay, or GDD. This is a term we reserve specifically for the little ones. Now, the definition has two parts, and you've got to remember both. First, the delay has to be significant, and it has to affect at least two different areas of development. It's not just about one skill. And second, and this is the real key, this diagnosis is only for children who are under the age of 5.
So, what about kids who are over 5? Well, that's when we shift to a different term, intellectual disability, or ID. This diagnosis also has two main components. The first is significant limitations in intellectual functioning, things like reasoning, learning, problem solving. The second is limitations in adaptive behavior. Think of adaptive behavior as all the practical, everyday skills needed for daily life: communication, social skills, taking care of oneself. And just a quick but really important note. Intellectual disability is the correct, respectful term we use now. It's replaced the old, outdated phrase mental retardation.
So if you take away one thing from this section, let it be this. The single biggest difference between GDD and ID is the child's age. It's that simple. You can think of GDD as a kind of working diagnosis for a young child. It tells us there's a problem, but it might or might not turn into a diagnosis of ID once they're older and we can do more formal testing. So remember, under 5, it's GDD. Over 5, it's ID.
Okay, so we've said that GDD is a delay in at least two developmental domains. But what are these domains exactly? Let's break down the 5 key areas we use to assess a child's development and get a full picture of how they're doing. So here they are, the big 5. Gross motor skills are all about the large muscles. Think sitting up, crawling, walking. Fine motor skills involve the smaller, more precise movements like grabbing a toy or picking up a piece of food. Then you have speech and language, which covers both understanding what's being said and being able to express themselves. Cognition is all about their thinking skills, learning, memory, and problem solving. And finally, we have the socio-personal domain, which includes activities of daily living. This is all about how they interact with others and manage basic self-care. A significant delay in any 2 or more of these, that's our criteria for GDD.
So now we know how to define it and how to spot it. The next big question is, why? Why does it happen? Understanding the etiology, or the causes, is a huge topic for your exams. But don't worry, we can break it down in a really systematic and manageable way. And this is not a rare problem. We're talking about an estimated prevalence of around 2.5 to 5% for GDD. What that means for you is that in any pediatric practice, you are absolutely going to see kids who need to be evaluated for developmental delays. It's common.
Now, this slide here is your secret weapon. The list of potential causes for developmental delay is massive and, honestly, a little intimidating. But you can organize it all logically based on when the problem started. Was it before birth, which we call antenatal, during or right around birth, perinatal, or after birth, postnatal? This simple framework is the key to memorizing and understanding the causes.
So let's start with antenatal causes, things that happen before the baby is even born. This bucket includes major chromosomal disorders like Down syndrome, other genetic conditions like Rett syndrome, and something called inborn errors of metabolism. We also have to think about infections that the mother might have had during pregnancy, the classic torch infections. And of course, exposure to teratogens, substances like certain drugs or alcohol that can harm the developing fetus.
Next up, perinatal causes. These are things that happen right around the time of birth. The classic one you'll hear about is hypoxic ischemic encephalopathy, or HIE, which is essentially brain injury from a lack of oxygen. Other big ones are kernicterus, which is brain damage from very high bilirubin levels, severe infections like meningitis right after birth, and brain injury from dangerously low blood sugar in a newborn.
And finally, we have postnatal causes. These can happen anytime during infancy or early childhood. Key things to ask about in the history are severe nutritional deficiencies, B12 and iodine are really important ones, exposure to toxins like lead in the environment, and sadly, both accidental and non-accidental head trauma. So, you've identified a delay, and you have this great framework for thinking about the possible causes. What's next? What do you actually do? Let's talk about the practical side of things, how to investigate and manage these kids. This is where we turn theory into real clinical action.
The single most important thing to remember about management is that it is never a one-person show. It is always a multidisciplinary team effort. A child's needs are complex, so you need a whole team of experts. The approach is pretty logical. Step 1, confirm the delay with proper standardized assessment tools. Step 2, investigate the cause, trying to find an underlying reason. And Step 3, which is the most critical part, get that child started with interventions from the team. Pediatricians, neurologists, physical therapists, speech therapists, psychologists, you name it.
When you're investigating, you have to be a detective. You don't just order every test in the book for every child. You use clues from your history and exam to guide you. This table shows it perfectly. For instance, you'd consider neuroimaging, and MRI is usually better than CT if the child has an abnormal head size or some focal neurologic signs. Genetic studies are really important when you just don't have an obvious cause, and screening for things like congenital hypothyroidism is pretty much standard for a comprehensive workup.
Whew, we have covered a ton of ground, so before we wrap up, let's just boil it all down into a few super high-yield takeaways. This is the stuff you absolutely need to have locked in for your exams.
All right, here is your rapid-fire recap. GDD is for kids under 5. ID is for those over 5. The definition of GDD requires a significant delay in 2 or more developmental domains. Don't get overwhelmed by the causes. Just remember to structure them by timing: antenatal, perinatal, and postnatal. And finally, management is never, ever a solo mission. It is always a multidisciplinary team effort. Got it?
And remember, learning to spot GDD isn't just about answering a question on an exam. It's about opening a door for a child. It's about getting them into early intervention services that can genuinely change the entire trajectory of their life. By understanding these concepts, you have the power to make a profound difference. Thanks for joining me today.